Hi, everyone. This is our 442 case study on diabetes, drug, and addiction. I'm Angie, and we also have here Heather, Jenny, Dee, and Diana.
So I'll go first. This is actually my patient I had last year for MedSearch 2. She was a 58-year-old Black female. She was married and she lived with one adult son, but she had 3 adult children. She would be considered lower economic status based on her housing and her income. She was originally from Oakland, but she was in town visiting her niece. She has a large family, which she considers her source of support. And she was not employed at the moment. She's periodically employed, but her husband works and she gets her health insurance through her husband. She feels alone though. She felt bored and lost since her kids are now grown up. And this led into her drug use, which is one of her chronic illnesses. She is currently addicted to heroin. And she was undergoing an opioid withdrawal when she was admitted. So originally she also has type 2 diabetes. She was diagnosed 5 years ago. And when she was visiting her niece, she ran out of heroin, started going through withdrawal, stopped eating, but was still taking insulin. So this led to a hypoglycemic event. Her blood sugar was 21, so she was admitted to the hospital. I took care of her in the PCU. So with this, we need to be talking with the patient about diabetes education, helping her understand when she needs to use insulin. And also we need to make sure we follow seizure precautions while she's there and aid her while she goes through withdrawal. Next slide. So next we need to look at the self-care for this patient. Before hospitalization, she was able to complete all of her ADLs and IDALs without any issues. However, she could still use some more education on appropriate diet and healthy lifestyle since she was obese and had hypertension. Now, this patient also rarely checked her blood glucose at home because she didn't have the supply. So this is a knowledge deficit that needs to be addressed. However, during her hospitalization, she was having difficulty meeting her self needs. She could do her basic ADLs like brush her teeth, but she had difficulty eating and drinking due to the nausea from the withdrawal. And she was also having trouble resting due to the pain. She also lacks self-management on avoiding drugs. So avoiding harm is one aspect of self-care that this patient really needs to be addressed with. And she would also spend money on heroin rather than diabetic testing supplies. This patient, she also refused to speak to her family while she was hospitalized. They would call and want to be involved with her care, but she declined to speak to them, and they could be a good source of support for her if she was willing to speak with them.
Next, I'm going to be discussing priority patient issues for discharge planning. Although we have some background information about our patient, we're not entirely sure what came first. Was it the chicken or was it the egg? Was her heroin use caused by her mental health, or did her mental health cause her to use heroin? In this case, we don't know, but we're going to assume that she started experiencing mental health issues first. With that being said, the priority patient issue would be addressing her mental health. According to Erickson's stage of psychosocial development, she would fall under the 7th stage, which describes generativity versus stagnation. In her case, she feels disconnected from her loved ones, her community, and society as a whole. She is not working and may lack sufficient social interaction with other individuals. It's equally important to address her mental health since it could result in increased heroin use and potential thoughts of suicide. The question we need to ask ourselves is if she will be safe after we discharge her from the hospital. The second patient issue we need to be concerned about is her actual heroin use. Heroin is a highly addictive drug that can cause physical and mental problems like depression or an unexpected overdose. It can also alter one's eating habits and hormone production. This makes it incredibly difficult for the body to maintain healthy blood sugar levels. Heroin can also counteract or reduce the effectiveness of this patient's diabetic medication. Other complications which are evident in this case include complications that can lead to hypo or hyperglycemic events. In this case, she used heroin, she started withdrawing and didn't get hungry, so she wasn't eating, but she continued to administer her insulin, which resulted in her experiencing a hypoglycemic event. Since we can't predict the future, we don't know if this event could reoccur, but it's our duty to provide our patient with as much information and resources as possible to help aid her in her current situation. Third patient issue we identified is her mismanagement of her diabetes. Her substance use is leading her to suffer complications from her current health conditions. So this patient requires patient teaching about the importance of monitoring her blood glucose and self-administering the appropriate amount of insulin. We also need to address her lack of medical supplies that are necessary for her to manage her diabetes. Next slide, please. So based on her current patient issues, our group would recommend this patient for an outpatient program and a residential treatment. Prior to discharge, we would provide this patient with flyers and brochures to these facilities and encourage her to call these locations for more information. If she decided to enroll herself, she could receive mental health counseling, have the opportunity to meet with psychiatrists and receive medication education, receive aftercare recovery services. I've added information for a directory of substance use disorder programs for adults, the San Diego Access and Crisis Line, and the Alameda Crisis Line. Next.
All right, nursing care management strategies for this patient. At the patient level, she would greatly benefit from the partnership strategy because this would help to promote her autonomy and would help to create long-lasting changes into her health. At this point, she's been trying to manage it by herself, and she would benefit from a partnership with her entire healthcare team, possibly even her family in the future. At the system level, this patient stated that she has been administering her insulin without checking her blood sugar. So she would greatly benefit from education as well as managed care. Managed care at the system level would help her to identify preventable risks that she could encounter with both her diabetes and drug addiction. In terms of patient empowerment, it's going to be important to assess what she already knows as far as receiving insulin, when to give it, how to do it, and then to ensure that she receives any further proper education that she needs, as well as discussing her treatment options. With empowerment, it's important for her to be able to have choices and to thus make the best informed decisions. As she transitions into a new lifestyle, she should be referred to an endocrinologist and communication be made with her primary care physician. This is going to help with continuity of care with her new healthier lifestyle when she returns back to Oakland. She has stated that she takes her insulin without checking her blood sugar, partly because of the fact that she can't afford supplies. So we can work with the Department of Managed Healthcare to determine what her insurance will cover and to help her out with her supplies. And lastly, with promoting health and recovery, it'll be important for continuity of care to perhaps send her to a Narcotics Anonymous group in Oakland. This will give her a safe place to talk about her addiction. And then, again, with patient education, proper diabetes care management, as well as possibly using an opioid withdrawal scale to help to determine management effectiveness and further plan her care.
In reviewing her utilization of the healthcare system, we found that she uses a primary care physician up in Oakland for the treatment of her chronic conditions, but she's overdue for an annual exam, and it's important for her to regularly attend these assessments so that they can detect any changes in her health. She has an endocrinologist, but she doesn't go to regular appointments, and she should be seeing him every 3 to 4 months to make sure that her glucose trends are being monitored and to get education on diabetes management. This could reduce the frequency of her healthcare crises, such as this emergency department visit. She overutilizes the emergency department because she has to come in for these hypoglycemic events, and she even uses it to restock supplies when she runs out. She should keep her PCP and endocrinologist informed of these visits so that they can have an accurate health record, and we should really focus on reducing these visits. She can receive health through using supportive care systems such as Jenny and Angie discussed, and this would really help bridge the gap between her knowledge deficits and offer her some support. Next. When we're looking at quality issues, we're mostly looking at safety and reducing costs and waste. Because she goes to the ED so often, the more we involve her in her patient care plan, the more likely she is to adhere to the recommendations for her chronic conditions. And we should also make sure we are appropriately monitoring medication, verifying her blood sugar before insulin, and appropriately wasting morphine because she is receiving small doses of morphine. For her high fall risk, we should have her close to the nurse's station, and we should round hourly. That is another issue in safety in the hospital, is that she's a high fall risk because she's withdrawing from heroin. She's also at risk for seizure. She's experiencing nausea and loss of appetite, which may affect her sugar and her electrolyte and fluid imbalances due to the frequent vomiting. So we should encourage fluid and monitor her labs regularly. At home, she should be aware of the safety risk of her continued drug use, and we should refer her to those support groups that we've already discussed, and her risk of repeat hypoglycemic events, and we can reduce those by getting her better at diabetes education. And we hope to use these tertiary prevention methods in order to reduce the progression of her chronic conditions. Next.
So to round out our case study, of course, we have to evaluate the interventions that we have implemented. For the patient level interventions, we focused on partnership to empower the patient to manage her diabetes and her substance abuse. With education on how the patient can utilize her insurance and other resources in Alameda County to obtain diabetic supplies, the patient verbalizes that she is more confident in managing her diabetes. She reported that one of her biggest obstacles was affording these testing supplies. With the proper supplies, she verbalizes that she will now be able to test her blood glucose before administering insulin to help prevent her hypo and hyperglycemic events. The patient also verbalized that she can now recognize the symptoms of her hypo and hyperglycemic events and understands that she can take actions to help stabilize her condition even if she does not have testing equipment available. For example, she now knows the importance of completing her meals or at least eating a snack if she feels like her blood sugar is low. Through counseling, we were able to encourage the patient to allow her family to help her with her recovery. After our conversations with her, she felt empowered enough to call her family back and slowly divulge the details of her struggle. There is still much work to be done and more conversations to have had, but at least they have started these conversations. Her family is now aware of her substance abuse problems and also aware of her desire to recover. And now, more importantly, she is accepting of her help and their support. For the evaluation of the system level interventions, our main focus of the interventions were on education and coordination of managed care to reduce the risk of harm. After our coordination of care and education, the patient is able to perform a return demonstration of proper use of her glucometer and administration of insulin. Her records have also been updated and sent to her endocrinologist in Oakland, and he has now been notified of her current condition to provide continuity of care. She has also decided to enroll into a diabetes management program in Alameda County to help reinforce her compliance to her treatment of care by obtaining a lot of resources in a support group. She also has verbalized that she has been connected to a Narcotics Anonymous group in San Diego and Oakland, so she does have a sense of support there. We also have to keep in mind that these evaluations can only assess what the patient verbalizes that she will do, and these interventions need further evaluation to see if the patient will stay compliant with her treatment plans. And that concludes our presentation. Thank you for your time, and thank you for viewing our presentation.